Whether you're a solo provider or in a group practice, Therapy Notes not only helps you grow your practice, but grows with you along your journey. With live customer support 24 hours a day, 7 days a week, and an extensive feature library, it's no wonder Therapy Notes is the #1 EHR trusted among mental health professionals. Try them for free for 2 months using promo code MODERN today.
Therapists, do you know if your clients are getting successfully reimbursed with the super bills you give them? Insurance can be confusing to navigate, leading clients to quit therapy early. Join hundreds of therapists who use Thrizer as their go-to resource for successful out-of-network reimbursements, helping them get and keep clients in their practice. Visit join.thrizer.com/modern therapist to learn more and get started.
You're listening to the Modern Therapist Survival Guide, where therapists live, breathe, and practice as human beings. To support you as a whole person and a therapist, here are your hosts, Curt Widhelm and Katie Vernoy.
Welcome back, Modern Therapists. This is the Modern Therapist Survival Guide. I'm Curt Widhelm with Katie Vernoy, and this is the podcast for therapists about the things that we do in our practices, the way that we approach our work. And one of the things that we may be guilty of around here is bad-mouthing evidence-based practices. And we talk about cog in the machine kind of things, like workbook therapy. Where does the clinician come in? I'm reluctantly admitting we may overestimate just how bad evidence-based practices are. And here to help us with that conversation is our good friend, group practice owner, Jessica Tappana. And she's here to help demystify and make it to where it's like, no, there is room for all of the wonderful things that Curt and Katie talk about and doing evidence-based practice. So thank you for joining us today.
Thank you for letting me join you. I, for like 2 years, have been listening to you guys badmouth evidence-based practice and been like, you guys don't mean what you're saying. So I'm going to set the record straight.
We're so happy to have you here. It's so wonderful to have good friends on the podcast. And we've been wanting to get you on for a while. We just finally made it. You had to travel the whole world and then come back before you had time to come on the podcast. But we're going to ask you the question we ask everyone who comes onto the podcast. Who are you and what are you putting out into the world?
Absolutely. My name is Jessica Tappana. I'm a licensed clinical social worker in the state of Missouri. I'm a group practice owner. I have a group practice in Columbia, Missouri that focuses on offering evidence-based practice primarily for trauma and anxiety, and have had that now for 7 years. And additionally, I have a second business called Simplified SEO Consulting, where we help other therapists get in front of their ideal clients and get matched with the clients that they work the best with, so we can all do our best work by seeing the clients that we feel we can really help.
And we had Danica, is she chief operating officer or something, like some fanciness? We had Danica on already. So we'll link to the episode with Danica talking about SEO and AI and all the good stuff in our show notes over at mtsgpodcast.com.
As you know, we start a lot of our podcasts with the question, what do therapists get wrong about whatever the topic of the day is? And this comes not from a place of shaming anybody, but just to help clarify misconceptions, help people maybe not make the same mistakes. So what do other therapists usually get wrong? Not us, but other
not
therapists.
Us.
Okay. And maybe us too. What do we get wrong about evidence-based practices?
To me, what I hear people get wrong time and time and time again, and it just is, we just assume that what evidence-based practice means is taking the human element out of therapy and becoming a robot. And I hear people talk about evidence-based practice as if what it means is just reading a book, to a client and, put a monkey there that can read and it's going to be able to do therapy. To me, it's about a lot more than that. First, my bias is my mom is an interventionist, as a researcher. And so I grew up with a mother who was an MSW, but worked in schools of medicine on these huge grants. And I got to hear her frustration. She would find these excellent interventions that would help alleviate stress. Her area of expertise was hospice caregivers. And so she would tell me, we've spent literally millions of dollars proving how helpful this intervention is. And then the minute the grant goes away, people stop using it. And I got to hear her frustration about that. Then I come and become and enter into the workforce myself, and I'm hearing therapists on the other side talking about all the problems that we have with implementing evidence-based practice, and particularly implementing these interventions in a way that's adherent to the methods. And I'm sitting here like, guys, there's a happy medium. When you've heard the researchers and you've heard the clinicians, I feel like often the points that we're making aren't contradict. When I started providing for NASW some trainings on evidence-based practice, I went looking for the definition of evidence-based practice, trying to find that happy medium. And what I found is every field that talks about evidence-based practice talks about the same three elements. They call it something different. They use a little bit different wording, but basically what they say is it's using well-researched interventions. So it is using something like DBT, EMDR, Gottman, whatever it is. And it's the combination of where that meets the expertise of the individual clinician and where the client's needs are, where we're considering their culture, their preferences, all of that. And I have not found any definitions of evidence-based practice. Someone's going to listen to this, correct me, and send me a definition. So I'm ready for it, but I've not found any definitions to date in like really respectable journals, really respectable, like the APA or, those sorts of things, or even the nursing association, the doctors, that contradict that we need all three of those elements if we're to deliver evidence-based practice. And if I am just going to a client and saying, every single one of you need me to read this cognitive processing therapy manual with not making anything to meet you where you are, that's not evidence-based practice, but that's what we often as clinicians think it is.
Where do you think these ideas around evidence-based practice is like this manualized, give a monkey a book that if they can read it, they can do this therapy. And I think at this point, it's more like put it into an AI bot and it'll be able to do this therapy. I think it's more accurate to what we're really worried about right now. Where do you think the ideas became so off base, so wrong from your perspective about what evidence-based practice is?
When I was in school, we talked a lot about taking an eclectic approach. It cracks me up all the time. Aspire Counseling's website is all about evidence-based practice, and I still get clinicians who will apply for a job. And what approach do you take? I take an eclectic approach. I draw a little bit from here and there and there. And so we, I think as a field, prided ourselves on this idea that we can take a little bit from a bunch of different theories and create this artwork almost of a beautiful therapy session. And we've seen so much magic in that. We know from the research that the single biggest thing that we have any control whatsoever on is the therapeutic relationship, that just having a good therapeutic relationship is going to make a positive impact. So therapists see all of these gains that they're making with clients, and then they hear somebody say, but you can make more gains if you're using DBT, if you're using EMDR, if you're using, the first evidence-based practice was cognitive behavior therapy. We hear that, and it almost feels like they're saying there's something wrong with what we were doing to start with. And so, of course, we're like, but there's magic in being eclectic. I do get annoyed because some of the well-researched interventions do make it sound like you have to be very exclusive and only hold to that. But I think a lot of times evidence-based practice can still be, I'm doing, when I do cognitive processing therapy with my clients for trauma, for instance, I still also do some DBT skills because I was a DBT clinician first. And so I don't think it's mutually exclusive, and I'm still providing evidence-based treatment, but I'm meeting a client where they are, that if they need this other thing, I'm going to pull from over here. That doesn't contradict the fact that my primary treatment modality is this well-researched intervention. It just means I'm doing good clinical work of meeting my client where they are.
The misconceptions or kind of the mental shortcuts that we make about EBPs is that they're cold, that they're just kind of very like matter of fact, here do this, here do this. And what you're speaking to, and even calling back to Katie's like, oh, this isn't just AI kind of doing this, is the warmth of the relationship that does that is part of how we're taught EBPs responsible for this. Like there's a lot of just kind of like break down kind of the human element at first to learn these skills, and then bring the human element back in that allows you to do what you just described with, all right, I'm doing cognitive processing, but I'm also going to pull something from over here, DBT, because this also will help you. Is it because of the way that we're taught this that we're kind of left with this foul taste?
I think it's the funding sources, because when you're looking at research, to validate a new treatment, they want to know that everybody's getting the same treatment. And in reality, in therapy, it's really hard for us to give everybody the same treatment. And so, if you've ever worked on a grant before, which I know many of us have, when you're working on a grant, it is very scripted. You have to do just this, this, because that's what the funder expects us to do. And I think that then becomes how we think of that treatment, when in fact, and often the the grants, or not grants, but any research that we're doing also excludes a lot of the population. And I've heard this at so many different trainings for different EBPs, where they say, okay, like, here are the results. And then you look at all the exclusion criteria and you're like, okay, yeah, you got great results, but you excluded most humans.
Right.
And I'm doing therapy with humans, folks. Like, I'm not doing therapy with your ideal person that only ever went through one trauma. They had a perfect life until they had one trauma. Their ACE score was like 0. And by the way, they're like just this very narrow age range, and they're obviously white. I mean, like, I'm doing therapy with humans that have a whole bunch of other factors and had huge ACE scores and have gone through, had complex trauma and then a single incident trauma, and on top of all their childhood stuff. To me, I think that's where it comes in, is when they're doing the research and they're validating it and they're like, you must do it exactly this way. Then it comes out and people think, oh, that's how you do evidence-based practice.
I guess the question I have then is, are we stopping the research too soon? Are we too narrow in the research? And so we need to get more into this place of having the evidence-based support more of and let's say eclectic, I'll say integrated approach, or a meet the client where they are approach. I mean, how do we actually move beyond this such limited scope of research, do you think?
First of all, I think some of them are. I know when I've attended professional conferences in the last couple of years, I am hearing more of the presenters say, and here in our exclusion criteria was less, or the good news is. And so I think that we're going to be moving that way. We started as a field trying so hard to prove ourselves that they had to be that rigid. And I think that there is a movement more towards including, but I think that the researchers are responsible, quite frankly, for making sure that they're doing that. But then on the ground, folks, what we've got to do is we've got to explain, okay, so it is important when you're doing, for instance, DBT, to use all 4 components, right? It's really important that you teach skills and that you're making sure that you're following certain formats, that you're having a skills group that's long enough to get something out of. But there needs to be a lot of guidance about how you teach that skill can vary greatly. You go look at 5 different DBT groups with different co-leaders and how they all teach it, because they're going to draw from their own personality. They're going to bring themselves and they're going to make it relevant to their clients. I don't think any of those groups are not doing DBT. So we need to be explaining what it means to do these evidence-based practice and where the human element is. You can teach a DBT skill and not just pull the examples straight from the book, but you also can, use this great metaphor that you've thought of, or this example you've seen, and that's still DBT, and that's okay. And I think teaching that is really hard, and giving that clarity, especially when you're often implementing them in larger agencies where there's higher turnover and really new clinicians who you're worried aren't going to do it to fidelity. But there are ways to do it to fidelity. It's providing good supervision. And if anyone needs to know how to do that, you guys have some excellent podcasts on providing good supervision.
Therapy Notes combines billing, scheduling, and notes into one easy-to-use streamlined software. Plus, they now also offer group telehealth and secure messaging features. No matter where your practice takes you, you'll have all the tools for success at your fingertips with Therapy Notes, giving you time to care more and worry less.
Learn more at therapynotes.com and use promo code MODERN for 2 months free. Well, and what you're talking about is a couple of things. Number one is being able to more accurately describe not just what is therapy, but what is therapy like with you. And you're illustrating that really well, because the DBT that we offer in our practice is probably going to look very different than the DBT that you offer. And the second piece of this is something that I really work with on my staff. Is it's not just teaching the skills, but it's also living the skills and being able to demonstrate that brings that human component right back into having this as a basis for it.
Exactly. I used to describe to people that if you call and you want to do, I'll use the example of DBT since we've started down that route. If you want to do DBT, I have these two, I had more than two, but I would use two of my clinicians as an example. You know, you can go with this clinician or this clinician. They're both going to do DBT, or they both could do cognitive processing therapy. They had some of the same modalities that they were using. But if you're in this session over here, you're going to have a whole lot of laughter. I'm sorry, we're just going to hear, it's going to be such laughter that we can hear him laughing from the lobby, you know, and he's going to use a lot of humor and it's going to be infused in there. And if you're over here, this is a former high school teacher they all are going to expect you to keep a diary card, but this one's going to basically approach it like a classroom setting almost. And she's fantastic, but their personalities were so opposite that sitting in an individual therapy session with them, we always knew was going to be very different, even though they were doing the same modality, even though they sat on the same consultation team and would staff cases together. How it would feel to sit in a session with the two of them was different. And that was okay and wonderful. And they were, but one of those clinicians has now moved on, or I guess they technically both have, to their own practices. But they were my perfect example of two totally opposite personalities who both were doing DBT to fidelity, both getting excellent results. We could see from the data that their clients were getting better, but they weren't just being a robot. They brought themselves to the session. And so if we're assigning clients, the amount of training we put into our client care team is huge, because when they're assigning clients, they need to not just say, oh, you have a lot of suicidality, you're going with DBT, or, oh, you have trauma, you need to go with one of these. But they need to also be able to describe who those therapists are and how they approach therapy, how they show up in the therapy room.
It's interesting because as you're talking, and I'm the only, I know DBT skills and that kind of stuff, but I've never done adherent DBT. So I'm the only one in the room not having done adherent DBT. But what you're really describing is actually distilling down a manual, so to speak, and saying, these are the important principles. This is what you're needing to hit. This is the information that needs to be shared. And so adherent DBT is not the manual. It's these principles and skills that need to be taught and those types of things. And I think that to me feels very, very approachable as far as a clinician who has a lot of experience. Like if I can learn something and kind of infuse myself into it and understand it and just say, okay, I got to hit these points, but how I hit them is up to me. That feels very doable. But I think going back to what you've said, Jessica, is that's hard to teach. And so do you have a sense of how, when someone is learning or teaching an evidence-based practice, how you can get to that distillation of this is the principle, this is the core, and this is how you can bring yourself in?
Yeah, in our practice, our two most manualized treatments are probably, we do both exposure and response prevention for OCD, and we do cognitive processing therapy. And so they're great ones to start our newer clinicians on, our interns, our provisionally licensed clinicians. In Missouri, interns mean still in school. But I know we all have different language for it, but our less experienced clinicians do like starting with some of those. I keep looking over the side because right next to me, I have the manual for cognitive processing therapy. And it's great because it is very, here's what you do in session 1, session 2, session 3. But how we teach it at our practice is using a lot of open-ended questions, asking our clinicians, how would you describe this? Okay, read this now, close the book and describe it to me without looking. And then I'm looking and I'm like, well, you hit these points, but make it yours. Make it, why do you believe it? A lot of times we use scales. And so we'll show, when we're talking about evidence-based practice, I think that having that belief in it is really important. And so we'll show some of the data for our clients who have gone through that treatment to help build that sense of confidence in it, and then ask them to describe that, to how they would introduce a client to it. It is more of an art, and I think it's harder to supervise someone this way than it is to just be like, okay, you went to a training for ERP, go deliver it, and we'll staff cases once a month specific to ERP. That would be way easier, but to do it right, we have for each of our primary evidence-based practices, and my group isn't huge. We're, I think, 12 clinicians at the moment. maybe 13. But for each evidence-based practice, we have a Google Chat group going of everybody that does that particular evidence-based practice. So you can hop in there and staff cases with our newer clinicians. They really need to be paying attention to that and going to the optional monthly consultations, because it is more of an art than just reading a manual. And they need to go beyond just one training. They need to hear different examples, hear different ways of doing it, and be able to staff, okay, this client doesn't quite meet the picture perfect thing, or this client has this request or this cultural thing that we need to consider. How's that look? We tell them it's like, you can grab one of us anytime. You can grab 3, 4 of us. We're constantly coming together and saying and encasing these, but it is harder. And I think from a practical standpoint, doing that in the larger your setting, in some ways, the more difficult it's going to be to figure out how to be able to have that sort of culture of lots of staffing the cases and lots of discussing how to individualize it, because it's not easy.
What you're talking about is making people practice it in order to be able to do it. Like there's a whole evidence base around, like, if you practice things, you're going to do better at doing them. And, it kind of brings the whole idea of what we do as a profession of, like, it's a therapy practice, which means that we should practice it outside of sessions. Otherwise, you're just doing therapy and subjecting clients to poorly practiced therapy, I guess.
Absolutely. We have to, you have to believe in it. You have to live it. You have to know how to use the skills. I think, the first couple of years I was teaching mindfulness, I still wasn't sure if I was doing mindfulness correctly myself, because my brain needed it so bad. I was like, am I getting this right? And so, yeah, I think having people live it, having people do the treatments that are going to resonate with them, or at least they can get to a point where it resonates. When I'm doing EMDR and talking about the container exercise, I will literally show clients the container that my container is based off of, because I have one. I practice this, and not every client, but when appropriate, I'll do that, when we're discussing it, because I think that having the clinician buy-in and having the clinicians not just buy in, but like you said, if I'm going to teach DBT skills, I better know how to use Dearman. If I'm going to do this, I have to believe in it and understand how it works, and understand the pitfalls and the discomforts with it, I think, to do the very best work.
While superbills can be helpful for your private pay clients, they don't help clients access therapy today. When clients see you weekly or biweekly, they may be out hundreds of dollars before they receive reimbursements 4 to 6 weeks later, which can be financially straining on them. Thriser's mission is to help clients access therapy today by working to get them instantly reimbursed for out-of-network sessions.
First, you can help your prospects instantly verify their out-of-network benefits with Thriser, providing them complete transparency on the cost of therapy ahead of their first session. Then, just by charging your clients via Thriser's payment platform, you can offer them courtesy claim submission and end-to-end claim management, and even let your clients just pay a coinsurance for sessions, similar to in-network copays, to skip the reimbursement wait entirely. How? Thriser covers the rest of your fees, so you get paid in full up front, and they wait for a reimbursement on your client's behalf.
Thriser also has a Superbill uploads feature, which is completely free for therapists, if you'd like to instead offer your clients a resource to manage their own superbills. Thriser manages all claims end-to-end, so you and your clients don't need to deal with any of the insurance stress. Visit join.thriser.com/modern therapist and use our promo code Modern Therapists to start your free trial and receive waived fees for your first $2,500 in payments.
You've talked about the data and being able to show, especially newer clinicians who are learning kind of what has happened in your practice. And we've talked about feedback informed treatment and that kind of stuff. So briefly, if you can talk about kind of what is the data that you're gathering, and how does that fit into how you set up your evidence-based practices in your practice?
Data makes people very nervous. I like data a lot. Talking about feedback informed care, one of my favorite things that all my clients do is the ARM5, so I can see, the impact of the therapeutic relationship. And my favorite thing that I tell all new clinicians in my practice, I'm like, when it goes down just 1 point, that's like the best thing, because that's them being honest, because they're not going to rate us too little, but they actually don't think we're as confident as we used to be. And so knowing that, we can go in and change. So in our practice, what it looks like, though, is because data does make clinicians nervous, I have minimized my requirements around it, other than you have to be measuring something associated with what you're working on with your client. And at least once a month, I need you using some measure. Now, some measures and some types of therapy we're going to use every week. If I'm doing certain trauma therapies, my clients are taking the PCL5 every single week so that I can see the progress. That's part of doing it adherently. But I try to give my clinicians the control to see data as a tool and not as like some punitive thing. I think that in some environments, it's become like this punitive thing. Like if you don't get the right numbers, that's somehow a problem, or you've somehow failed, when in fact, it's not about that to me. To me, taking those measures, whether it's the PCL5 or the GAD7 or the PHQ9 or the ARM5, is to be able to go back and tell my clients, show my clients the data. We use a system where then I can share screen with clients, or if they're sitting in the session with me, I can turn it, because they're like, all they can see is here they've worked so hard and they still feel crummy, and they see that. And so then I'll show them the data and I'll be like, look, this is the progress this shows you make. How does that feel to you? Do you feel that? And a lot of times that's when it'll start triggering. Oh yeah, I did used to be that depressed and I am less depressed now. And so for us, it is about thinking about what data is going to be most useful to that client and to the clinician, more so than me being super prescribed about it. Because I would love to tell all of my clinicians exact which tools to use for what, but I think that my therapists are using the data more because I give them a lot of freedom. And at this point, when I first said you had to start using some sort of screening tools and measurement to be able to track client progress, I thought I was going to lose half my staff. They were so upset at me. They fought it hard. And now all of them are like, I couldn't practice without this. And I'm like, good. That's great.
What do you find that helps? Because I think that there's a parallel between using things that work like ERPs and using things that work like eliciting client feedback through this stuff. What do you think it is that really helps clinicians in those capacities to adopt it? Is it just as simple as like do it and find that it actually works and get over yourself?
I think it depends. We can all debate different ways to do this. For me, I try to get their buy-in, but at the end of the day, when I made the decision that they were all going to start using some sort of measurement tool, that I had to force on them. I had to just say, that's it. I'm not going to require you what you do, but like you're just doing it, and I'll give you control where I can. But I think that a lot of it too is we have this fear of being judged. It's a fundamental human fear, right? We're worried that we're doing something wrong. We're worried that we're going to be judged. I think when we're talking about about asking somebody to practice evidence-based practice, they're afraid they're going to get wrong. And if they go to consultation or you review a video and see they got wrong, they're going to be in trouble. And so I think it goes back to being able to create a culture of vulnerability, and one where, we will have clients that don't make progress. We will have times where, we're in a session and we're not adherent and we're quite frankly superhuman and totally screwed up, and that and being okay with that. But it's hard because we just have that natural fear of doing it wrong. We have that natural tendency to be self-conscious, and that fear of if we're going to get punished, or worse yet, fired if we're not adherent, or if we're not having clients show that they make progress. But that very fear can cause the problems that lead to those things to happen.
How do you set up that culture? To me, I'm hearing a lot of growth mindset and that kind of stuff, but what are the tools or the tricks or the strategies that you use to try to set up that culture of allowing humanity into implementing evidence-based practices?
From the time I interview, I describe evidence-based practice as being not just offering a well-researched intervention, but also you bring yourself to the table and you meet clients where you are. So from day one, we're talking about that. We're talking about the role of humility in therapy. I actually ask in interviews about their greatest failures as a professional, because I want to know that they have the humility to tell me what that was. And if they give me some like write-off answer, I'm like, really? That's all you've ever done? Like, lucky you, because I think that I want to set up from day one that we're going to all be human and we're all going to be learning, and that evidence-based practice isn't going to be neat and tidy and easy to implement, but it is going to be messy. And then as far as the culture aspect, once they come on, it's giving the support, it's talking about it, it's people demonstrating that vulnerability. Once you have a few people bought in, it's a lot easier to get everybody else bought in, because they see that somebody else admits that they were wrong and nobody's getting in trouble for it. Where, I'll show where I went wrong on a regular basis. I'll be like, yeah, look at this data from my client. Look, it went down there. It was great. It was the best thing that ever happened when that data went down, because we changed up what we were doing this way, or I found out this about the client. And I encourage the other people in formal or informal leadership positions within our practice to do the same.
By the time that you're interviewing people, they've presumably been through their internships or practicums, whatever it's called in your listeners' jurisdictions here. It seems like this is a novel thing that many interviewees are experiencing with group practice owners like yourself, like mine, some of the other group practice owners that we interview, where it's like there's coming out of grad school that it's kind of like, oh, evidence-based practice means that if I don't do CBT with 95% accuracy and results, then it's a failure of myself as a human being. And it seems like such a novel thing in interview processes like yours, where it's like, no, like we can do everything right. Are we failing students in like presenting this in ways of like, here's how you do this stuff? Is this kind of more of a systemic problem that we're facing, and you've just kind of cracked the code into having a successful group practice by reintroducing humanity into therapy?
I I think that would be a great question for all of those that do teach in universities, because I think that there are reasons, I personally have had never had any desire to go teach at the university level. And I think a lot of it does come down to the problems that I see with the way people are being educated. But that's one of the reasons that I love, actually, we do bring people on when they're in that final internship in school and our practice. And so far, 100% of the students that we've brought on have then been hired after graduation. But I love getting in there while they're still in school and being like, here's our approach. Go talk about it in class in your thing, and come back and tell me if they have anything they can say to contradict me, because I have yet for them to come back and say, and any of the students that we've worked with come back and say, no, my teacher said that there is no way that you should, do that with whatever. And so I would love to see the schools bring more into humanity. I think that our institutions, our universities, have such a difficult job of getting enough information in there and staying stuffy enough, is the term I would use, to have validity in the eyes of society, but also having that humanity piece in there. I wouldn't want to create university curriculum. I think I'd be horrible at it.
But you're kind of a rabble rouser. Like you're saying like, hey, interns, come over to this little practicum over here, and I'm gonna teach you all this stuff, and you're gonna go and infect your university with all of my rabble rousing ways.
Yeah. That's my role, is to be the outside instigator.
Alternate rebellion, living those DBT skills.
I loved it. I had an intern last year who was, or a practicum student last year, who was splitting their time between us and another site. And they did the same treatment. They did cognitive processing therapy. It's both. And I loved hearing about the other one and how it was much more manualized. And then being like, and here it is manualized. There are literal like scripts. It's very, but have you thought about doing this? And I loved reviewing the video and giving the feedback of, well, where are you in this? You're a human. You have all of these really cool intersecting identities that make you who you are, this particular clinician. was working with clients that needed to see themselves in therapists. And I was like, where do you show up? How are you reaching your clients? And I just loved that they were getting both approaches, that they were getting the same exact treatment in two different locations and being able to come back to me and say, here's how it compares. And can I take this over to, one time they wanted to borrow a book to take with them to their other site. And I'm like, yeah, absolutely. Take that, go spread good treatment everywhere you go.
Where can people find out more about you and your practice and your business?
Absolutely. So my private practice website is aspirecounselingmo.com. And then my SEO business is simplifiedseoconsulting.com.
We'll include links to Jessica's stuff in our show notes over at mtsgpodcast.com. Follow us on our social media. Join our Facebook group, the Modern Therapist Group, to continue on the conversation. And until next time, I'm Curt Whithelm with Katie Vernoy and Jessica Tappana.
A final thanks again to our partner Therapy Notes, the highest rated practice management solution for behavioral health. Don't forget that you can use promo code MODERN for 2 free months when you sign up.
Super bills and reimbursement waits are not a reliable solution for out-of-network clients. With just a click of the button, you can offer courtesy claim submission and end-to-end claim management support, and even allow them to skip the reimbursement wait altogether with Thrizer. Visit join.thrizer.com/modern therapist and use our code Modern Therapist to start your free trial today.
Thank you for listening to the Modern Therapist Survival Guide. Learn more about who we are and what we do at mtsgpodcast.com. You can also join us on Facebook and Twitter. And please don't forget to subscribe so you don't miss any of our episodes.